Looking ahead for a very successful SDDF forum as usual. It is my absolute honor, and I'm really honored to actually present during this conference in front of my colleagues, mentors, and especially, it wasn't planned, but I'm also presenting in front of one of our guest speakers, Professor Jamie Greger, who was my program director many years ago. So no pressure there. Okay, Bismillah ar-Rahman ar-Rahim. How can I go back and forth, please? Okay, so first, maybe before I start with the main presentation, special thank you to the SGA for supporting the field of GI nutrition. So we know that here in the kingdom, or maybe across the world actually, the field of GI nutrition maybe is not the most popular. I know at least from observing our trainees, the majority are really fascinated by all the advanced endoscopic procedure, the new IBD biologics, hepatology, same thing. And I think, again, there's no, nutrition is everywhere, right? So if you're an advanced endoscopist, if you're an IBDologist, if you're a hepatologist, it's just a big part of being a gastroenterologist. Is to actually, you are involved in nutrition. And so the SGA came up with this initiative to actually form a GI nutrition interest group, which with my colleagues started last year. So we did a workshop last year and this year that was successful, alhamdulillah, and we're planning to proceed with this workshop annually. So everyone is welcome to join this group. So my objectives for today is first, I'm just going to give an overview about the changing clinical presentation of celiac disease, whether here in Saudi or across the world. I'm going just to give I'll talk a little bit about the gluten-free diet. What are the pros and cons of gluten-free diet in patients with celiac disease? And I will just outline a general approach to nutritional assessment and monitoring in these patients. So we all know that celiac disease is an immune-mediated disease. We now like to describe it as a multi-system disease, so it's not purely gluten-sensitive enteropathy. It is actually a multi-system disease that involves many systems. And again, speaking of nutrition, we think that many of the extraintestinal manifestations, or at least some of them, could be related to nutritional deficiencies or excess. So celiac disease is one of the most, if not the most common immune-mediated condition. I'm not going to talk about the pathogenesis in detail, but again, you know that you need someone who's genetically susceptible, exposed to gluten, and then the T-cell mediated pathway goes on. But of course, it's more complex than that, and there are many other factors in the pathogenesis of celiac disease. We know very well that celiac disease is an autoimmune condition. It's totally different from wheat allergy, which is an IgE-mediated condition. And it's totally different from non-celiac gluten sensitivity, which is becoming a little bit, maybe, I'm sure maybe many of you went across a lot of publications discussing this entity. Some people would argue that it's not actually a condition, it's more of an IBS-like condition. There are no clear diagnostic criteria for non-celiac gluten sensitivity. But celiac disease, of course, is definitely an autoimmune condition. In terms of the prevalence, we know that it is a worldwide disease. We believe it is a worldwide disease, not only a disease that affects in the Western countries. Estimated global prevalence around 1 or 1.4%, but it depends if you look at the serology-based studies or if you're looking at the biopsy-based studies. It is more common in women. It can happen at any age. In the US, for example, the mean age of diagnosis is 38 years old. So what about here locally in Saudi Arabia? There are actually many really good studies that came out here from the Kingdom of Saudi Arabia. Most of them, however, addressed the prevalence of celiac disease in high-risk populations like type 1 diabetics, patients with other autoimmune conditions. But at least what we can say that the prevalence of celiac disease in Saudi Arabia is at least as common as other Western countries, if not more actually. Most of these studies were serology based. So we know, and again, this is a worldwide problem, is although it is a common condition, it's really commonly missed, either not diagnosed, underdiagnosed, or there is a delay in the diagnosis. And of course, a delayed diagnosis there are studies showing that the delay in diagnosis can go up to maybe 10, 13 years. And this, of course, is associated with significant number of complications. Many countries now are really interested to dig in this further because we know that both undiagnosed celiac disease and diagnosed celiac disease are associated with burden. Burden not only on the patient, but there's also burden on the community. There's burden on the healthcare system. So this is really an area of interest for many reasons. So should we screen everyone for celiac disease, screen high-risk patients for celiac disease, or should we adopt the case-finding strategies? So far, at least, we don't have any guideline recommendation suggesting that we should screen everyone for celiac disease. However, at least most guidelines recommend a case-finding approach in patients who are at risk for celiac disease rather than screening. However, I should mention that some countries now are, so I'll give an example of Italy. So Italy last year started a mandatory program for screening all children under 18 for type 1 diabetes and celiac disease. So this is a new thing that is happening in Italy, and it will be interesting to know the outcome and to know whether or not this is also applicable here. So again, all of you are familiar with the clinical manifestations of celiac disease. Just to highlight, again, we have a good number of literature here from Saudi Arabia showing that it is actually very common for patients to present with the non-classic symptoms of celiac disease or just present with anemia. Another thing, speaking of nutrition, is the change in phenotype. So we're seeing more and more patients who are overweight or obese at diagnosis. So this is also very, very important. So when we talk about malnutrition, whether in celiac disease or in any other chronic condition or chronic GI condition, always remind ourselves that when we say malnutrition, we usually mean either undernutrition or overnutrition. And this is also the case in celiac disease, and I'll talk about this more in details. But we know that early detection of any form of malnutrition is important, as this can improve the outcomes. So malnutrition, of course, it makes sense, is very common in celiac disease, but not only because of the celiac disease itself and its effect on nutrient absorption, but it is also probably related to the quality of the gluten-free diet, because it is associated with certain deficiencies. Again, all of us are familiar with this, with the diagnosis of celiac disease. I just want to remind everyone that the celiac disease can be patchy, so that's why in some patients the presentation might be different. Nutritional deficiencies, again, there might be some variability, so that's important to keep in mind. Still, the test of choice, of course, for diagnosis and for monitoring with some limitation, it is tissue transglutaminase IgA antibodies. So typically, at least in the adult population, when we have a positive celiac serology test, we proceed with an upper endoscopy and proceed with a duodenal biopsies. All guidelines strongly recommend that we take 2 biopsies from the duodenal bulb and then take 4 biopsies from the first and second part of the duodenum for a better yield. and also maybe take one biopsy per pass for a better oriented specimens. So this is very interesting. I'm sure our pediatrician colleagues know that all the updated celiac disease diagnosis guideline in the pediatrics now moved to the non-biopsy approach in diagnosing celiac disease. So if you have a patient with a strongly positive TTG IgA antibodies more than 10 times upper normal, and then on a second sample had a positive endomysial antibodies, which is a fairly specific antibody test. In these patients, you can actually diagnose celiac disease without biopsy. Now, why is this relevant? I find this relevant when we later talk about nutritional follow-up, is if you don't have a baseline biopsy, then when you follow up these patients, you will probably rely more and more on gluten-free adherence testing and other assessments rather than mucosal recovery, because you don't have a baseline biopsy. Again, we're all familiar with the basic pillars in managing patients with celiac disease, but again, it's easier said than done, and there's a really big variability. We know this from a lot of studies. It depends on many factors, but we know the basics that it involves that you really need to educate the patient properly. You need to involve a good experienced dietitian in these patients. They need support groups, and they need a long-term multidisciplinary follow-up. So there are many advantages for the gluten-free diet in a patient with celiac disease, including improvement in their symptoms, improvement in their serology, hopefully mucosal recovery, and prevention of potential long-term complications, including bone disease and malignancies. We know that there are many, many challenges for any patient who is newly diagnosed with celiac disease worldwide, including the cost, the label reading, the availability. There are social restrictions. Thankfully, here in the Kingdom of Saudi Arabia, the government made sure that many of these obstacles are being dealt with, including providing patients with gluten-free products or stipends. The Saudi Drug and Food Administration also are making great efforts in terms of labeling. We have a dedicated Saudi Society for Celiac Disease, and of course, many academic centers are actively involved in this as well. I should mention, everyone knows that Saudi Arabia will be hosting the World Cup in a few years from now, so we expect a lot of tourists coming to Saudi Arabia, and I imagine many of them, or at least maybe 1% of them, will be looking for gluten-free restaurants. So I'm not going, again, to go through a lot of details here, but everyone knows that any patient who is newly diagnosed with celiac disease usually goes through an intensive education, and this is initially with the fundamentals of what is a gluten-free diet, hidden sources of gluten, and the gluten-free grains. Oats, again, is always debatable, but we know that frequently oats can be contaminated with gluten, so many would elect to restrict oats at the beginning until the patient is improved, then gradually reintroduce oats. Most countries use this limit of 20 milligrams of gluten per kilograms, and I think this number came from one of the older studies showing that exposure to gluten more than 50 per kilogram is more likely to cause enteropathy. So do we have treatment targets for celiac disease like Crohn's disease? We wish we have. There are basic treatment targets, but still they're not as good as or clear as patients with IBD. But they involve, of course, clinical symptomatic response, improvement in their quality of life. We would like them to have improvement in their serology, antibodies, and eventually mucosal recovery. So usually if a patient starts on a gluten-free diet, we expect many of their symptoms to improve within weeks or months, their serology to also improve within months. Mucosal recovery tends to take longer in many patients. However, again, it's not as simple as this. So there are some facts that Actually, being compliant with a gluten-free diet is not very common, so many patients will not be compliant to a gluten-free diet for many reasons. And of those who are trying to be compliant, they will actually consume gluten involuntarily. And that even in these patients, that mucosal recovery is not always possible. So who will follow these patients? And again, when you look at the literature, you see a wide range or different models, actually. So when you look at the countries like the UK, there is a study in the UK that surveyed patients, and they found that most patients prefer a dietitian-led clinic with having a physician as a backup. Whereas, for example, in Finland, where celiac disease, again, is very common, most of these patients, especially the stable ones, are being followed in primary care. However, for us as gastroenterologists, we're always involved in these patients, especially when there are red flags. So for any chronic condition, especially any chronic GI condition, whether in the inpatient setting or outpatient setting, we have to screen our patients for malnutrition. And there are different screening tools that are validated for either inpatients or outpatients. One of the famous ones for inpatient is the NRS 2002, and for outpatient, the MUST screening tool is very popular for outpatients. However, unfortunately, none of these tools have been validated specifically for celiac disease. In IBD, actually, I think there is a Canadian, and there is from Saskatchewan, an IBD-specific screening tool that has been developed and validated. So following screening your patient for malnutrition, the next step will include nutritional assessment. And unfortunately, most of us, or many of us, believe that our part is done and now it's all dietitian. But the truth is, this is not the case. It has to be multidisciplinary. So because nutritional assessment, as you can see in this figure, involves many things, including clinical, physical examination, anthropometric measurements, dietary review, including reviewing the details about the gluten-free diet, and so on, social, metabolic, and so on and so forth. Again, unfortunately, we still don't have any nutritional assessment tool that is specific for celiac disease. However, again, my role as a gastroenterologist, when I refer this patient to the dietitian, is maybe try to identify whether or not my patient is a patient who is very straightforward, can be followed with a primary care physician, dietitian, or is this a patient who is maybe likely to have a poor response or delayed response. And this is from many studies showing that patients who are diagnosed later in life, patients who present with classic malabsorption, patients who are poorly adherent, might take longer to improve or to achieve clinical response, biochemical or mucosal. Again, for us as gastroenterologists, it is important to always keep in mind causes of persistent symptoms and manage these accordingly. I have already talked about this. So this is for...
Hani, we have 1 minute.
2 minutes? Okay, so I'm going to finish in a couple of minutes. So for anyone who's interested about details on monitoring this, there has been actually a newly published guidelines detailing all steps on how to properly monitor a patient with celiac disease. Before I conclude my talk, I just want to highlight that, again, a gluten-free diet is associated with a lot of nutritional deficiencies and associated with excess in calories, fat, and sugar. This is a very interesting systematic review that has been published last year, showing that it is actually very common for patients with celiac disease to have fatty liver and metabolic syndrome at diagnosis, which also increases following a gluten-free diet. The mechanism, there are the classic causes of MASLD, but there are probably additional mechanisms that causes MASLD in patients with celiac disease. Always look for eating, so we talked about overnutrition, now we're talking about undernutrition. Always in your patient look for maladaptive eating behaviors, because celiac has also been associated with anorexia and other maladaptive eating behaviors. Again, just for the sake of the time, I just want to here to highlight from this slide that micronutrient deficiencies are very common. However, some of them improve with a gluten-free diet, but again, when you come a year later, you notice that some of them might actually persist, and this is again related to the quality of the gluten-free diet, not necessarily the celiac disease itself. And studies has actually looked at this, and it has been proven. And again, just for the sake that a gluten-free diet is safe in patients with celiac disease and results in symptomatic in patients with celiac disease. Nutrition assessment and identifying deficiencies are crucial in these patients. And for us, because we discussed overweight and obesity, assessing their metabolic risk is very, very important. A multidisciplinary approach will highly or more likely lead to better outcome in these patients. Thank you so much.